Hi, my name is Dr. Shane Lieberman. I'm a palliative care physician here at Valley View. Welcome to Valley View University. I'd like to thank everyone for joining us today. I have a few housekeeping items to address before we get started. You can submit your questions through the Q&A chat at the bottom of your screen, and we'll try to get to the questions at the end of the presentation. We'll try our very best to answer these questions. We are unable to answer questions regarding personal health information, so please don't put your name or your birth date in the chat there for us. Okay. All right. So today I'm going to talk about palliative care. Um, I am a board certified palliative care physician. And my objective for today is pretty much just to talk about what the heck is palliative care, who we are, what do we do, and why a person would possibly need palliative care. So I'll start at the beginning here. Disclaimer, this content is only for informational purposes and should not be used in place of actual doctor's visit. Okay, so let's start with what is palliative care. So palliative care at the heart of it is an extra layer of support. So you can have quality of life while getting treatment for serious illness. So this is our specialty. This is quality of life because we like to say you can live well while living with heart failure, COPD, cancer, any of those serious illnesses that you might have. So our focus is quality of life. Palliative care is specialized medical care for people living with a serious illness. So palliative care is a team of specially trained clinicians working as a team who focus on improving quality of life, easing symptoms, and strengthening coping for a patient and family. So we provide relief from the symptoms and the stress of illness, and that's really important as well. Because when you're living with a serious illness, there's a lot that's going on. It's not only the disease itself. It's not necessarily just the symptoms. Now you have a lot of doctor's appointments. Now you have a lot of maybe possibly some new medicines. You're going to the pharmacy. You're trying to keep everything straight. Sometimes, getting to work might be an issue, or maybe there's lots of stuff going on that could be while you're trying to have a good quality of life. So it's based on the needs of the patient, not on the patient's prognosis. So this leads me to my next topic is about who may benefit from palliative care services. So any person diagnosed with a serious illness at any stage of diagnosis. Okay, so this again, our focus is on quality of life as you're going through your treatment, as you're going through whatever the doctor is saying you should be doing this. So who may benefit from palliative care services? So somebody that has a change in functional status might be a good time to come talk to us. So what does that mean? So change in functional status might be, last year I skied 100 days. This year I don't know if I'm going to be able to get 5 days. Or it could be more, I used to, hike regularly or get to the pool regularly, and now it's harder to do that. Or maybe it's harder to get out of the house or even get to the bathroom. Maybe it's time that my family wants to consider. Maybe it's time to move to assisted living or something like that. So any of these changes in functional status can be very stressful for people, and maybe a good time to come talk to the palliative care team. Difficult to control symptoms. So we are experts in symptom management. We work a lot with the cancer patients and help with cancer-related pain, or if people have bad heart disease or lung disease, shortness of breath, or maybe I'm just having trouble sleeping, or dealing with depression or anxiety. These are the kind of things that we talk about regularly. Um, Often we say, maybe it's time to meet with us if you have multiple hospitalizations or ER visits. Say this is my maybe this is my third hospitalization this year. The first time was for a fall and I, hurt my ankle. Second time I had a pneumonia. But these kind of things often happen and maybe are signs that it's time to let's talk about everything that's going on. Um, and then it's also for people who want to discuss goals of care, advanced care planning, or code status. So I'm going to talk about each of these things kind of independently. What do these mean and how do we go about talking about these things? So goals of care. So living well is important to most of us. The medical system that we're in, is only concerned about longevity. We're trying to make a person live as long as possible. And that makes sense for most of our lives, but quality of life is often important to most of us as well. I don't just want to be in a bed, or I don't want to be, not able to think clearly. That's not enough for a lot of us. So, but it's individualized. So as we meet with patients, we get to know who you are and who a person is, what's important. That's kind of part of our goal, our job. So goals of care is kind of how we refer to what is important to us. And then this is a quote from a patient I had a number of years ago, and I repeat this often because it was somewhat of an anomaly. But it was a man, um, probably in his mid 60s, and his life was pretty tough by kind of any standards. Um, Basically, he was living in his motor home, and he wanted to drive it to Florida one last time to see his mother was his major goal. But he didn't have any tires on the motor vehicle, and there was like holes in the floor, and the mice were getting in and eating the electrical wires and those kind of things. And then, health-wise, he had really bad teeth, but he also had very bad lung disease and very bad heart disease. So every time he went to the dentist, he said, "Can you fix my teeth? Can you fix my teeth? I need to be able to eat." They would say, "We can't put you under because you're too high a risk because of your heart disease or your lung disease." So he was really struggling in kind of all aspects of life. And as I got to know him and we're talking and he's, telling me what's going on in his life, I said, what's important to you? And he said to me, "Doc, any day I wake up on this side of the dirt is a good day." And I always use this guy as an example because um, people say that to me, and that's fine. That's what was important to him. He was a survivor. The most important thing to him was that he keeps on surviving. Most of us have this quality of life that's important to us as well. It's not just about surviving. Sometimes it is, but most of the time we want to be able to enjoy the things that make life valuable to us. Time with family, time with eating, being able to recognize our loved ones or our friends, being able to converse, being able to get out of bed. Those are important to most of us as well. But this guy, any day on this side of the dirt's a good day. I've had patients say, as long as I can watch the Broncos in my recliner every Sunday, that's good enough too. So it's very individualized, and that's what I like to try to learn about people and figure out what is the most important, so we can talk about what the medical care might look like going forward. So goals of care conversations allow a person to identify what's most important to them in life. So it takes this conversation with myself or one of my colleagues about kind of let's learn about who you are and what's important to you so we can make sure your medical care is tailored to your goals and your values. Now, advanced care planning is the other side of thing. And this is your, we talk a lot about control. When a person gets a serious illness or my body's not doing, what I wanted to do, I don't have control over what my body's doing. I didn't ask for this cancer diagnosis, whatever it is. This is your chance that you can speak up and have a say in your care. Um, here's a story that might kind of explain it a little bit better. Helen knew what a living will or advance directive was, but hadn't done one. She just retired at age 65 and was settling down to a new life with her husband of 30 years. Watching the news, she feels lucky that she doesn't have to depend on her old paycheck. When her daughter Sandra asked her if she had a living will, Helen said, "You'll know what I want if something bad happens." She didn't want to think about it, but her daughter persisted. She said, "Actually, I don't know what you want. My friend's mother got sick and none of them knew what to do. I don't want us to go through that same thing." So Helen thought about that a little bit, and she went to one of her friends and said, "Hey, do you have a living will?" And to her surprise, her friend said, "Yes, I have a living will. It's easy." Helen went to a website her friend recommended and then talked to her daughter and her husband. And they had a good family talk. And Helen and the family felt a little bit more at ease. So, this is the other thing that we say treatments only work if they work for you. If you're undergoing cancer therapy and the docs say, "Oh, you got to do this, you got to do this next chemo, you got to do this is what's going to fight your cancer." But if you're having trouble getting out of bed or you're having trouble doing the things that you really enjoy, and the chemotherapy may be hindering some of that, it might not work for you. Or you have bad heart failure, the doctor says you got to eat, you got to cut out all salt out of your diet, and this is how you do it. Well, I really enjoy eating. People can say, "I really enjoy eating. I'm not really willing to do this." So this is the other maxim we go by. Treatments only work if they work for you. So talking to your doctors, talking to someone like me, talking to your family helps make sure that you get the right care for you. Here's another little story that might help explain this. Bill, 55 years old, he's the main caregiver for his mother who has diabetes and bad kidneys. She doesn't seem to be thinking clearly, and Bill knows that he will need to make medical decisions for her soon. His mother was on his mind when Bill went to his doctor, and his doctor asked what Bill would want for his own care. Bill said that his independence was important to him and that if he couldn't take his own shower or get out of bed and things were not likely to improve, he wouldn't want his medical treatments to focus on living longer in that condition. Bill's wife felt good about having this discussion, and Bill's doctor put a form in his medical record so all of Bill's other doctors would know what he had said. And this is what we refer to as advanced care planning. In Colorado, this is what I always say is the most important form a person can have, and this is the medical durable power of attorney for healthcare decisions. So we will always ask the patient, the patient, what is it that you want from your care? What is it that you want? But if a person is not able to respond or a person is not able to comprehend the data, either because they're unconscious or confused, this form allows a person to maintain the control and be able to say, if I can't talk for myself, if I can't understand the medical information put in front of me, talk to this person. They know me, they know my values, we've had some discussions. You can talk to them to make medical decisions on my behalf. That person is called the medical durable power of attorney. And this is what the form looks like. In Colorado, it's very simple. You do not need notary. Merely need to kind of fill this out that says, "I name this person," and this is their phone number. There is room for two alternates on here. I often say we know families will talk amongst themselves if there are any big decisions together. This is just the person that we can contact first. You sign it, you date it, it goes in your medical record, and then everybody in the hospital system here knows, who to call in case you're unable to make decisions for yourself. We say that everybody over the age of 18 should have one of these forms, just in case. So this is an easy form to fill out, and we do encourage everybody to do this at any stage. The last thing here is about code status. Now, what is code status? Code status refers to resuscitation or CPR. This is asked any and every time a person is admitted to the hospital. Do you have a code status? Have you talked about CPR and what this might mean for you? Now, there's often a big discussion around this. I'm going to touch on kind of why we talk about this. Number one, I often say that CPR is kind of the most extreme measures that we do to people. And just to clarify, CPR only comes into play if you have no heartbeat or is not breathing. In other words, you have already died. This doesn't change if you pick, I don't want CPR, it doesn't change the rest of your medical interventions. You can still go to the ER, you can still have surgeries. If you have a heart attack, you can still go to the cath lab and get stents in your coronary arteries. It doesn't mean if you have a heart attack, it's just that you have no heartbeat or not breathing. So we talk about a DNR code status or a do not resuscitate. Um, DNR also means allow natural death. So do everything, all the medical interventions necessary to prolong my life, but it comes to the point where I've actually died. Please allow me to go naturally. So that's what a DNR is. Now, so why is it important to discuss? So this is why I often think it's important to discuss, because it is considered extreme measures, and um, the default is that if we don't ask about it or we don't talk about it, the default is that we will do CPR on everybody. And CPR makes sense for most of us for most of our lives. But as we get that diagnosis or as our health is changing, it may not make sense for us at all stages. So when we look at the data after CPR, so if you are in the hospital and you have a cardiac arrest, your heart stops, and you're in the hospital and the nurses are right there and all the equipment is right there, about 25% of all comers will survive to hospital discharge. And then about 2/3 of those have good neurologic outcomes, which is important to most of us. So about 15% in the hospital will survive to hospital discharge, still being able to walk, talk, all of those things. So that's, you know, not bad odds, not great odds either. Um, Now, if you have a cardiac arrest outside of the hospital, those numbers go down significantly. And large data shows that about 8% survive with good neurologic function. 8% is about 1 in 12 people. So about 1 in 12 people that have an out-of-hospital cardiac arrest survive with good neurologic function. On the converse side of that, of course, 11 out of every 12 people that go through this don't survive or don't survive with good neurologic outcome. What it means for a lot of people is, of course, when we look at the data, and the way I talk about it too, is most people don't return to their same baseline function. So if you're going into into a resuscitation attempt, and you're already weak, if you're not moving that well, if you're not eating that well, if it's harder to get around, any of those things, you probably won't return to that same level. So people will say, well, if I've died, it doesn't matter. Do what you can, do whatever you want. Well, the reason why it may be important is, number one, it is very painful. It is very traumatic. It's very traumatic to witness. If anybody has ever seen a real CPR attempt, not exactly what they show on television, but it's traumatic to family or friends who have to witness their loved one going through something like that. If they're doing proper chest compressions, they do break ribs every time. And again, with this value of quality of life, I often say to folks, the worst outcome might not be if they do CPR and you survive, but a worse outcome might be we do get a heartbeat back. And then what? And then you may end up in one of those states that is unacceptable to you. So I think it's really important in this conversation, as we outline what a person's values are, to include this in the conversation. If someone is older or someone's already has some significant disease, to really consider if CPR still makes sense for somebody or not. If you are at a point where you say, that I still want aggressive medical care. I want chemotherapy. I'll go to the hospital if I have to. I'll go to the cath lab, and if I have a heart attack, any of that, that's all fine with me. I'm looking for that, but maybe don't do the CPR. So if you are in that category, this is the other form that a person needs, and this is called the Colorado Medical Orders for Scope of Treatment, or the MOST form. Um, and if you will see here in the A section here, this is the whole reason we do this form. It says right here, person has no pulse and is not breathing. So that's the only time this comes into play. The reason why you will want this form, if you choose this no CPR, is this protects you um, from the hospital, from paramedics doing CPR. The story goes, if you don't have this form and paramedics come to the home, they have to do CPR unless you have this form. If you look here at the bottom, it is signed by a physician or a medical provider. So this is actually a medical order. It's bright green. This form is bright green for a reason. If paramedics come to the home, they will look on the back of the front door or on the refrigerator for a bright green piece of paper. So that's why we do this form. If this applies to you or a person, and CPO no longer makes sense for them based on where they are in their life. Okay, so common misperceptions about palliative care. So palliative care is not hospice. Palliative care does not limit your options about what your medical treatment is. Palliative care is about meeting you where you're at, figuring out what quality of life means to you. So we are not hospice. We are not solely for end of life. Our goal here is to help you live well as you are living with your illness. So why and how do we do it? So we get to know who people are. We have good conversations with people, finding out who you are, what's important to you, and then making sure that your medical treatments are in alignment with your values and your goals. We like to think that we're very skilled at communication. We try to take a holistic approach to a person. Again, finding out who you are. I've had many people come to me, or I've had doctors say, "Oh, I explained it really well to them. I spent a half hour with them trying to, explaining everything about their illness and what the treatment's going to be, and we talked about everything." And then the patient comes and sees me and says, "I have no idea what's going on. I have no idea what the doctor was talking about." So I like to think that we're really good at coordinating your care with the other doctors, kind of boiling down medical information. Let's put it at a level that's important to you, not just what's out there. We know medical interventions can be burdensome. So talking about these things that are important to you to make sure it makes sense. And we also know that coping with illness is difficult. So we like to help with that side of things as well with our support. So if you or someone you know is interested in learning more about palliative care, or kind of meeting with me or anybody on my team, we have an outpatient clinic here at Valley View in the GMA building on the second floor. We also have telehealth, which is very helpful for patients, especially if they're dealing with lots of symptoms, or it's more difficult to get to they usually have lots of doctor's appointments. We get that and we understand that. So we do offer telehealth as an option to meet people. I always say, of course, we love sitting down in the same room with somebody and getting to know them, eye to eye, but telehealth works for us in this day and age as well. And it's often more convenient for people. So if you need to access palliative care, you can ask your primary care provider or your specialist. Although you don't need to, you can self-refer and just give us a call, and we can get your records from wherever we need to. We also have an inpatient Valley View Hospital team. So if you are admitted to the hospital, sometimes patients will ask to see the palliative care team, and so a lot of times the primary hospital is the primary provider that's caring for you while you're in the hospital. Say, hey, maybe this is a good time to meet with the palliative care team. They're really good at helping with symptoms. They're really good at talking about some of these things. So we are in the hospital 5 days a week as well. And this is, I like this a lot, palliative care. We'll figure this out together. Let's make a plan for your care. And that's kind of what our goals are. Let's help you wherever you're at in your stage of illness. Let's see if we can help, help you, help with your quality of life. Let's find out what's important for you. And that's basically what we do. My email is here at the bottom. This is our website for the palliative care team on the Valley View website, and then our clinic phone number is here. Yeah, I have, that's my presentation for today. I do have some time for some questions if there are any questions.
Can you discuss palliative care for dementia patients? Is palliative care a good option for them?
Oh, what a great question. Um, I I think it's very important for dementia patients to start talking about palliative care. I really am a big proponent of talking about to folks with their caregivers, with their loved ones, with their families, whoever they have in their lives, early on in the disease, I think is the most important thing, especially if a person can still communicate their wishes and what's important to them. So in this vein of making sure that a patient or a person gets the care that they want, dementia is a really it's a progressive disease. We, as of now, we don't have great treatment stuff coming out all the time, but we kind of know what the course of dementia might look like. It can be a very slow process, but having the discussions early about what kind of medical care makes sense is really important, especially for dementia patients, could have been very active or, very high functioning, and can be very impacted by this illness of dementia. So talking about, is there a point where, what medical intervention makes sense, at each step of the way, if it continues to progress, are these the medical interventions I want at this point? Are these the medical interventions I want at this point? And kind of having that discussion again and making sure both we, the medical care team, knows what those wishes are at this point in time, as well as the family or medical power of attorney, and starting those conversations early, I think is always very important. But that's a really good question.
Okay. A couple questions about the MOST form. So how do you get a MOST form done? And does the MOST form need to be green? There's a white copy that can be downloaded from the internet.
Great question. Great question. So the MOST form does not have to be green. Often I do say that, like, if paramedics come to the home, they look for a green piece of paper. So, but it doesn't have to be green. If you have a piece of paper taped to the back of the front door, they'll know what it looks like as well. So it doesn't have to be green. But good question. So it's typically green because that's just the convention of it. Where do I get a MOST form? So online is a good choice. Like I said, though, you do need a provider's order. It is a medical order. So, if you've, talked about it, thought about it, and said, you know what, CPR probably doesn't make sense for me. I should really fill out this MOST form. Talk to any of your providers. Any, primary care doc, myself, cancer doctor, pulmonologist, anybody can sign that form as well. But it does need to be signed by both either the patient or their medical power of attorney if a patient can't sign, and then a medical provider. Great question, though.
What is the difference between a DPOA and living will?
So the DPOA, or durable medical power of attorney, again, is the person. The form that I kind of showed before, that medical durable power of attorney, is just the form that you fill out to designate the person. So, and then what was the other one? Living will. So The medical durable power of attorney is the person who can make decisions if I can't make decisions for myself. I don't know if I mentioned in Colorado, it doesn't automatically go to spouse. It doesn't automatically go to children or parents. And if a person does not have a medical durable power of attorney, there is a longer process that either the hospital has to go through to contact all interested parties to find out, hey, who can make decisions for this person? So I always stress that everybody should do a medical durable power of attorney. Now, so that designates the person. The living will is the form. So the form sometimes lawyers do this. Sometimes you'll find stuff online. Sometimes people have heard of 5 wishes, and these are forms of living wills. And these just say they're variable in what they say. So sometimes they will say stuff like um, provide moisturizer for my lips if my mouth is dry. And, of course, everybody would want that, or a cool wash rag to my head if I feel hot, easy stuff like that. And then sometimes they say stuff like, especially the ones we see from lawyers will say, um, continue life support for 14 days if I'm, on life support. And those can be good. Any of these can be good to kind of help lead to the conversations about what's important to you. But I always say, like, it's good to have those documents, but it's more important to have the conversation and say, hey, I talked to Dr. Lieberman in 2025 and said, I want to make sure that I can maintain my independence. I never want to live in an assisted living. I want to be able to feed myself. I don't want to be a burden to my family. Those are the things that are most important to me. So then when a medical decision comes in front of you, whether it's CPR or if somebody is on life support or something like that, you can use kind of those guideposts and say, these are the things that are important to me. Does this intervention make sense at this point in my life? Because you might fill this out when you're 70 and you don't have any medical problems at all. And you say, yeah, well, sure, do life support for 14 days before you consider pulling the plug if the doctors say this isn't going to get any better. But then, 5 years later, I haven't updated my living will. And now I've been undergoing chemotherapy for stage 4 cancer for 2 years now. So that what you said in 2025 might not make sense in 2030. So the living will is a good form to have. It can start the conversation, but I always say the conversation is kind of the most important thing. Making sure that your wishes are met, that your values are met. But really good question.
Does palliative care do home health care for post-surgery patients? Would I need to talk to my primary care provider about that?
Yeah, so it is definitely different. Um, Again, post-surgical care, home care. Home care can mean a lot of different things. But palliative care is typically not post-surgical. Palliative care is not a chronic pain service. Palliative care can help coordinate your care if your surgery is in conjunction with other things that are going on. But we're not a home-based service at this point. We don't have a home palliative care need, but pretty much we're a supportive care service for folks that do have a serious life-limiting illness.
How do you measure levels of pain and deal with it?
Yeah, pain is a really it's a really complicated topic. What we understand about pain, um, the way I approach pain is really based on function. So I often don't say, pain management. Again, I don't do chronic pain. I do deal a lot with cancer-related pain. Um, but pain is almost entirely on function. Like what can I do? Um, I don't put a ton of stock into my pain is a 5 out of 10 or a 7 out of 10. And again, especially in regards to cancer related pain, I will say, um, are you able to sleep through the night? Are you able to watch a movie or read a magazine article without just focusing on your pain? Are you able to enjoy a meal with friends or family without just focusing on your pain? Um, you know, basically, with any kind of pain, chronic pain, cancer related pain, a goal to get like zero pain, my pain's going to go away, is not ever really a realistic goal. So it takes a multiple modality approach to approaching pain. Like what's a realistic goal for pain management? And what are we trying to achieve here in terms of function, in terms of quality of life, and making sure that those goals, hopefully we can meet those goals with the pain management that we provide. But another good question.
If someone in their 50s has lung disease, fibrosis, and knows they will need a lung transplant, can palliative care assist in that process? If so, how?
Yeah, great. So some of the bigger, great question. Some of the bigger facilities that do lung transplant, kidney transplant, heart transplant, any kind of transplant, it's a big deal. Bone marrow transplant. These are big invasive procedures. Um, you know, Talking about like what is this going to look like going forward? Is there somebody that can help with function, or is there somebody that's going to be able to help with pain or some of the side effects after the transplant? Do we have enough support to kind of go through something like this? This is how palliative care can help. If somebody is otherwise, has fibrosis of the lungs and they're, a young person, lung transplant totally makes sense. It's still important, I think, to kind of start these conversations and saying, look, you're going to be going through this is big. This is a life-changing thing. So let's work on this together. Let's talk about this together. What kind of support do you have going in? What kind of tools do you have for these kind of things? How can we help strengthen the tools you already have? And then, just making sure that people know that, hey, we're going to be there with you at every step of the way, helping you with symptom management, helping you with coping, helping you with the additional stresses of going through this. But I definitely think that anybody going through something as big as a lung transplant, definitely palliative care should be mandatory for sure. Just to kind of like, let's get to know you. Let's talk about it. And, hopefully everything goes smoothly. You go on your way. You have a great life. Perfect. Like that's what we're all hoping for. And if there's hiccups or speed bumps along the way, we'll be there for you. So I think that's kind of how I think that's what I think about palliative care and how we can be of assistance to people as they're going through this.
Due to my Parkinson's, I feel I am depressed more often than not. Could palliative care help or my primary care?
Yeah, I think I think definitely. I think Parkinson's definitely a serious illness, a life-limiting illness. Definitely affects quality of life. So I think palliative care can be helpful. Both with the depression piece of it. I am a physician. I do prescribing. I do prescribe antidepressants. Sometimes it's just talking about it, and sometimes medicines are the answer, and sometimes it's like, hey, we should find you some counseling or someone to talk to. So I can be a good source of that. Primary care also can do a lot of that stuff. Sometimes they do have behavioral health a little more accessible than I do, if that's kind of what's called for. Sometimes it's let's talk about the big picture. Let's talk about, what are the underlying fears here so we can start to address those things and look at it from a more holistic or a bigger picture kind of perspective to kind of say, this is what's going on. Yeah, and this is hard. And let's set some realistic goals. Let's talk about how we're going to make today as good as possible, or how we're going to make this week without kind of thinking about all the what ifs and how do we keep our mind in a present kind of space, as opposed to, it's very natural for us to kind of get overwhelmed with all the what ifs and all the anxiety that can go along with with this. So I think it's a good, safe space to talk about these things. I often, one way I kind of describe sometimes what we do, it's not all that we do, but we walk to the edge together, and we walk to the edge and we look over the edge together, um, and then we walk back to safety. But we look at it together, we talk about it, and then we come back to our safe spot. But we can look at this and learn how to kind of deal with what serious illness is and how it might affect me and who I am. So that's one way I look at what we do as well.
That is all the questions we have.
Okay, thank you. So our team would love to hear your feedback on today's presentation. If you have the time to fill out a quick survey, it will appear right after the webinar has ended. If you could take a moment just to fill that out, we would really appreciate that. If you want, well, even if you don't want, you're going to receive an email with the recording of the webinar within the next 24 hours. The next Valley View University is Thursday, October 23rd at noon with the Heart and Vascular Center's physician assistant Trevor Gerber. He's going to be discussing aortic valve disorders. Thank you all again for joining today. Have a great afternoon.